Ludhiana, KIMS, at Gangaram, and at RGCI. So his extensive, pretty much, all-round experience. He has had multiple scientific presentations at various radiology meetings and multiple publications as well. And he is, a really fabulous teacher from whatever we have heard about him. He has earned distinctions including the KCR Travel Grant and the ECR's Invest in the Youth Award. And currently, he is the director and consultant at Akshat Diagnostic Pharmacy. And he's going to speak today on cardiac CT from image acquisition to clinical decision making. Really looking forward to this, Akshat. Just before handing it over, just to let everyone know. So tomorrow is, our Society of Thoracic Radiology collaborative webinar, and it's going to be by Jitesh from MD Anderson, and is going to speak on imaging approach to mediastinal masses. These are free access videos, and these are the handles to follow. So with that, I'm going to stop my share, and over to you, Akshat.
Thank you, sir. Good evening, everyone. So we'll just dive in straight.
Let's see if you can share a screen.
Okay, so good evening, everyone. Good evening to all the juniors, colleagues, and seniors. Let's hope so we learn something out of this. So we'll be talking today about the cardiac CT. If you feel like anyone feels like interrupting in between, please do so. I won't bite. So what we'll be doing.
Just to update, let you know. So there's the Q&A. The attendees would be unable to speak, but we usually put the questions on the Q&A.
Okay, perfect.
And sometimes on the chat box, but we prefer the Q&A. So at the end of the session, certainly there'll be a detailed Q&A session as well.
Sure. Okay.
Yeah, and you are free to answer it if you want to in between as well. So entirely up to you.
Definitely. Okay. So I'll just summarize what we are going to do today. So we'll start with the heart, anatomy, pathology. Why do we want radiology of the heart when we already have cath angiograms and echo already? And then we'll look at some of the cases, and then we'll just look at some of the studies which have already been done. And then we'll just conclude the class. So simple class, nothing great. So coming to the anatomy part, heart, as we all know, it's not a very big organ. It's just slightly larger than a clenched fist. It is located on the left side of our chest wall. The right side of the heart receives the deoxygenated blood. The left side pumps the oxygenated blood to the body. So that was the importance of the heart. Now, this is just a anatomical diagram which we all used to see in our anatomy books. We have a right pulmonary, left pulmonary, anterior and inferior surface. The right pulmonary is made by the right atrium, the inferior by the left ventricle, the anterior surface by the right ventricle, and the left pulmonary by the left ventricle. That was the boring stuff. Now, this was what we used to see in our books, superior vena cava, inferior vena cava. Now, what we'll be talking about today, we'll be mainly talking about the coronaries, which are 3 in number. So we have a right coronary, a left main coronary. The right coronary goes towards the right. The left coronary goes towards the left. Actually, it is not named according to the direction in which it goes. It is named according to the direction from which it originates. So we have a coronary cusp, which has 3 parts, right, left, and a non-coronary cusp. The right coronary cusp gives rise to the right coronary artery. The left coronary cusp gives rise to the left main. The left main again divides into the left anterior descending and the left circumflex branch. Why the circumflex is named so? Because the circumflex circumnavigates and goes posteriorly. The left anterior descending, simple in its name, anteriorly descending. Okay. So we have, as we talk, we have right coronary artery. It arises from the right sinus. It runs in the right atrioventricular groove towards the inferior interventricular septum. It supplies the blood to the sinoatrial node 60% of the times, right atrium and the ventricle. So we have the branches, which are the conus branch, sinoatrial node, atrial branches, right ventricular branches, acute marginal, and the posterior descending artery. So we have a lot of branches coming out of it. So we have then a left main coronary. This is the variable in length. It can be present, it can be absent, it can be a short one, it can be a long one. It gives rise to the left anterior descending and a left circumflex branch. Then we have a left anterior descending branch. The left anterior descending, it arises from the left main. It has multiple number of branches which are numbered either diagonal branches or septal branches. So the diagonal branches are numbered from D1 to DX, D1 being the first diagonal branch, and then subsequently D2, D3, D4, as and on we can go. The left anterior descending, it supplies the anterior wall of the left ventricle, and it gives rise to the septal perforators. Now, coming to the circumflex coronary, it arises from the left main, courses inferiorly, and goes in the left atrioventricular groove. Now, the important thing we are seeing everywhere gives rise to the PDA. We saw that in the right coronary as well. So most of the times we'll come to that in the next slides. So this is the one, the dominance, which is the important part. The right coronary dominance, the left coronary dominance, the codominance, and superdominance. Now, if you have a right coronary dominance, how do we decide this? We can decide this by the posterior descending artery and a posterolateral branch. So the posterior descending artery, most of the times, it comes from the right coronary. But if the posterolateral branch comes from the left circumflex, it is a codominant. So we have a codominant thing where the right and the left, both the things are supplying the majority of the posterior wall. Now, if we have posterior descending and posterolateral branch supplied from the right coronary, it is a right dominant. If both the arteries come from the left circumflex, it is a left dominant. So right dominance, left dominance, codominant. Most of us are right dominant, being 60%, 25% are codominant, and 15% are left dominant. So how do we remember right dominance is more important? Let's just remember that right-handed people are more than left-handed, and which are more. So we have right dominance more than left dominance. So then again, if we have normal arteries, we can have anomalies also. The anomalies can be in origin, in the course, in the termination. This is just a very small list. There are many more anomalies going into this. So when we are originating, what can be the problem? The right side getting originated from left, the left from the right, or in some formations. Then we can have, rather than two main arteries, we can have a single coronary artery. We can have origin from a non-coronary cusp. And then anomalies of the course, which can be a myocardial bridging. All the slides will coming in the subsequent slides. We'll discuss everything in detail. So in short, why are we discussing the coronary anomalies? Because they can be either benign or a malignant. In coronary terminology, malignant does not mean cancer. Benign means the anomaly is safe. We don't need to be worried about the anomaly. It is not life-threatening. It does not cause major arrhythmias or any problems. Malignant means it can cause potential ischemias, arrhythmias, or even certain cardiac deaths, which we all have seen is happening a lot more in young people and even in people who go to gyms and everything. So coming back to the original anomalies, this is the normal thing. Right from right, left from left, posteriorly non-coronary cusp giving rise to nothing. The pulmonary artery is located towards the left side of the aorta and anteriorly. So we have anterior, right, left, posterior. Okay. Now, a benign anomalies, B, C, D, E. These four are our benign anomalies. So how do we say it? Benign anomalies. Okay, so a malignant anomaly will have an interarterial course. What do we mean by interarterial? In between the arteries, in between the two major arteries, that is aorta and a pulmonary artery. So any originating anomaly which does not follow the interarterial course is a benign anomaly. In this, we can see a right coronary artery giving rise to a left circumflex vessel going retroaortic. Left main giving rise to the left anterior descending. This was the normal thing. The anomaly was LCX originating from the right coronary. Similarly, we can see a right coronary giving rise to the LCX and left anterior descending. So this will be a single coronary, not single coronary. This will be a two coronaries originating from the single coronary cusp, no coronaries from the left, or the non-coronary cusp, but going in front of the pulmonary artery. No problem for this artery as well. Again, left main originating from the right coronary, going retroaortic. This is in front of the left pulmonary artery. Now, these two, F and G, are the malignant courses, where a left main artery is getting in between the aorta and the pulmonary artery. Again, right coronary going in between the pulmonary artery or the aorta. These are the malignant courses, because if demand of the body increases, these arteries, especially the aorta, tends to pump more. When it pumps more, it dilates, and when it dilates, it pinches off the anomalous artery in between. So here we can see the CT images. We can see the right coronary artery originating from the left coronary cusp and going towards the normal course. Here is the zoomed out version where the right coronary artery is taking the interarterial course. Again, this is the single coronary artery giving rise to the right coronary as well as the left main. There are no two separate arteries originating from single cusp. It is a single coronary artery giving rise to right and left as well. So we saw in the anomalies, there is an anomaly called myocardial bridging. So what do we mean by myocardial bridging? We have three layers of heart: endocardium, then epicardium and myocardium. So myocardium is in between the muscle wall, the endocardium is the inner side, and the epicardium is just outside the myocardium. So normally the arteries are located in the epicardial fat. These are not located in the endocardium, nor the myocardium, nor in the pericardium. They are located in the epicardial fat. The muscles are located just at the base of the arteries. But in some cases, what happens is these arteries can be located for some course of their traveling inside the myocardium. When it is located in the myocardium, this thing is called myocardial bridging. Now, why is myocardial bridging significant? Because the muscles are going to pump hard. They are going to be in systole and diastole. So during the systole, they are going to create more pressure. During the diastole, they are going to get relaxed. During the systole, they are going to pinch off this part. Now, no arteries are totally myocardial. No arteries. So it's not like that the whole left anterior descending will be in the myocardium. Some portion of the vessel will be inside the myocardium. Some will be in the epicardial fat. Most commonly, we see this anomaly in the left anterior descending mid and distal branches, and secondly followed by the left circumflex. Right coronary arteries are very less seen to be have myocardial bridging. Now the important things to note, sorry. Now the important things to note with myocardial bridging is that in a reporting of the cardiac CT, the length of the bridge, that is how much millimeters or centimeters of the segment is inside the muscle. It can be 1 millimeter, 2 millimeters, 5 millimeters. The depth at which the segment is located, it can be 0.1, 0.2, 1 mm, 2 mm, and for which segment it is located. So let's, in the reporting, what we'll say, the middle part of the left anterior descending, which might be located at around 10 centimeters from the ostium of the left main, located at a depth of 5 millimeters. And the last point, which is most important, how much is the effect of the systole on the myocardial bridging segment? Is it actually causing any hemodynamic alteration? That is it actually causing any stenosis during systole, and is it causing relaxation during the diastole? Or is it just the epicardial roofing that is involved? How is it important? The CTVR surgeons will need to know this, because he would like to unroof the segment involved, or he would like to continue with the conservative management, or he would like to bypass the segment, depending on this much information. So you are changing the management completely just by giving 4 words. Then continuing to the coronary artery disease. So this was the normal part. We had normal anatomy, normal anomalies. Now, why is the heart? So we have various pathologies related to the heart and everything. This is a very huge, we have multiples of books. We cannot cover this in a single class, so we'll just try to brush up with everything. So, starting with the coronary artery diseases. A coronary artery disease, why is it important? Because a huge number of people are getting converted from communicable diseases to non-communicable diseases. Non-communicable disease, again, cancer and heart diseases topping the list. So in India alone, it is zero point 0.8 to 26 per thousand people who have coronary heart disease. What is the problem? The problem is the non-flow limiting unstable plaque. Every word has its own meaning and importance. Non-flow limiting. So we have a plaque which does not limit the flow. Now, how is it possible? A plaque does not need to be 100%, 90%, or 80%. A plaque can be as small as causing 10% limitation, 20% limitation, 30% limitation. So that indicates what we are going to do with the management of the patient. We can have either the patient on statins, antiplatelet drugs, we can have the patient on bypass grafts, we can have the patient on stents, we can have the patient dead, because it all depends on the plaque. Now, we have stable plaques, unstable plaques, we have stable anginas, unstable anginas. So the unstable plaque is the problem because it can rupture and cause thrombosis and multiple segmentations, which is more dangerous than a stable plaque. We'll discuss that in these coming slides. So what up till now, what we used to do, how we used to proceed, will all come in the upcoming slides. So the CAD burden, that is the coronary artery disease, is 54 million Indians are right now affected. It has an earlier onset than the West, higher in diabetics. What are the risk factors? The risk factors are diabetes, hypertension, dyslipidemia, genetic predisposition, high refined carb diet. We as Indians are topping everything. Diabetes, yes. Hypertension, yes. Dyslipidemia, yes. Genetic predisposition, we are badly affected. High refined carb diet, we are all consuming. Outcomes without risk stratification. Now, if we have a younger MI is anything less than 50 years of age. It is higher mortality at first event and poor long-term survival. So how did we reach everything? Nothing just came, let's do. No one just woke up one day and started deciding that we'll do everything on a CT and we'll get everything out of it. So it all started with studies. We are doctors, we are scientists. It all starts with the basic hypothesis and upcoming evolving thesis. So the first of this was a Framingham study. It was based on a 10-year risk of developing cardiovascular disease. The factors involved in this study were age, sex, BP, cholesterol, smoking, diabetes, and antihypertensive therapy. This was not an Indian study. So the good point about the study was it was cheap and it was a population level tool. So it studied about the basic factors which affect the cardiovascular diseases for primary prevention. We have a primary, secondary, tertiary, and quaternary preservation. Primary preservation in SPM, it used to be basic prevention, not diagnosis and treatment, but to prevent it at the grassroots level. But it had a poor predictive individual accuracy. It had a population role, it did not have an individual role. It can tell you that this population is at a greater chance of developing cardiovascular disease, not a particular person who might have more BP, but belonging to a particular population. So there was no rule in therapeutic reclassification. So you can tell Indians have a higher risk, but you cannot tell that if I have a higher risk or not. So you understand this, right? So therapeutic reclassification was not possible based on this study. It underestimated risk in the young and overestimation in the elderly. Then we had the MESA study. MESA was multi-ethnic study of atherosclerosis in 2000s. So multi-ethnic, it involved multiple genetic predisposed groups. So the sample size was 6,800. For the first time, it involved coronary artery calcium scoring. We'll come into that in future slides. So coronary artery calcium, just remember that. We had plaques. Plaques can be of multiple types. One of the plaques types can be a calcified plaque. So this study established coronary artery calcification as a global standard for subclinical atherosclerosis detection. Subclinical, which is not clinically available. The person does not know I have a plaque or atherosclerosis or narrowing. So coronary artery calcium scoring could be done in a subclinical case and can be used to refine the statin decisions. Then we had a PROMISE study, prospective multi-center imaging study for evaluation of chest pain. Sample size was 10,000. Stable chest pain and intermediate pre-test probability of cardiovascular disease were the main inclusion criteria. It studied CTCA, that is CT coronary angiography versus functional testing. Random groups were allotted, followed for 2 years. No major difference in major adverse cardiac events. But the important point to be noticed here was CTCA reduced unnecessary invasive angiogram with normal coronaries. More preventive therapies were followed in the CTCA groups, and it highlighted the diagnostic clarity. Then came the Scottish counterpart. PROMISE was a US group. Scott Hart was a Scottish group. The sample size was 4,000. Stable chest pain, similar studies, 5 years follow-up, and it showed that CTCA is more appropriate for percutaneous coronary interventions prior to percutaneous coronary interventions. Then we come to the basic pathology. Pathology is macrophage foam cells depositing, then starting in the future years, small pools of lipid get deposited, starting of calcium deposition, calcium gets deposited, then it leads to the complicated lesion, that is a plaque, unstable plaque, where we have a lipid pool, calcium, then throma, thrombus, fissure, where macrophages are there. And this unstable plaque is the one that is going to be a problem for everyone. So for coronary artery calcium score, these two will be 0 up to here because no calcium is identified. But we can see that coronary artery calcium is still late in its course because you can see a narrowing, mild narrowing of the lumen is there, but no calcium is detected. Then we have calcium deposition, but by this time, a good amount of plaque has already been started to develop, and we might have a vulnerable plaque in the future years as well. Then imaging modalities, every imaging modality can be about heart. X-ray, echo, ultrasound, nuclear medicine, CTs, angiography, MRI. So chest X-ray, screening, used for screening. It was a conventional, it was cheap, less radiation, easily available. But the problem was it was not as informative for us as it could have been. Then comes the echocardiography. Echocardiography is excellent about the hemodynamic information. It gives you very good hemodynamic information about the ejection fraction and everything. Then we have intracardiac anatomy, which is very good with echocardiography, the only limitation being the bone and air window. The extracardiac information and the coronary information is limited. Then comes coronary angiography. Coronary angiography, as we all know, is a cath lab based angiography study of the coronaries where we selectively hook in the coronaries. It can be a right coronary, left coronary, or a flush aortogram where we see the path of the coronary arteries. We check for it is a gold standard, definitely. Then we check for the luminal narrowing. If there is any plaque, how much problem it is causing. So it can be either a diagnostic or an intensive therapeutic angiography. A diagnostic just means we go in, come out, we just see if there are plaques and how much is the plaque damaging the coronaries. In a therapeutic, or that can be converted from a diagnostic to therapeutic in the same sitting, we can just go in, see that the plaque is causing more than 50% narrowing, and we just put in a stent in the same sitting and come out. The only problem, we are damaging the arteries because we are going either by the radial artery or femoral artery. There can be chances of arterial injuries. Again, if it is not for a therapeutic study, diagnostic study can be done by CTCA as well, which can give you an extraluminal information, which is much better, and a global cardiac picture. Because a coronary angiography will give you an intraluminal, no wall, no outside the wall. So coming back to this picture, a coronary cath lab based angiography will give you this inside the lumen, not the wall, not the outside wall. So if we have something sitting outside, let's say a thrombus, a tumor, anything else, maybe just muscles which are hypertrophied, that might be pushing on this myocardial bridging, Myocardial bridging is pushing it. The patient can have angina, can have arrhythmias, but inside it will be clean. Then comes the nuclear medicine. Nuclear medicine are mainly for the functional assessment. Thallium and technetium based uh, compounds are used. They don't give any information about the coronary angiography, coronary lumen. So what matters? The ventricular size and the function, information about the stenosis and coronary arteries, and even the bypass grafts, pulmonary vein anatomy, myocardial perfusion. Then comes the cardiac CT. So what are the benefits? What are the problems? These are the advantages. It is non-invasive. It has high spatial resolution. Fast 3D data can be acquired, and it gives you global assessment of extracardiac and cardiac anatomy. The problems, radiation, contrast is needed, gating and motion artifacts. The patient has to be very still, less hemodynamic information. So this is a brief picture. So we have a left anterior descending, left circumflex, and a right coronary. These are the multiplanar reformatted images for the cardiac images. These are the 3D VR images. Then we can even look at the aortic valves. So why is aortic valve important? We'll come to that. So the clinical indications, why we are doing CT coronary angiographies. Because if we are not going to give any clinical implication, then we might as well not do anything. So it can be as basic as a health checkup. We are just worried about your health. We don't want to be caught off guard by a heart attack. We want to know where we are sitting so that we can start the medicines. What is the health checkup criteria? Anyone above 40 or 45 in India can get a CTCA angiography done. Even beyond 30, no problem in that. It's totally one's choice, but the books say 40, 45. Then suspected coronary artery disease in patients with intermediate risk chest pain and equivocal stress test result. A stress test was done before CT, it came equivocal. That was not conclusive. Intermediate risk chest pain. If you have a high risk chest pain, you already know you have plaques, you already know you have a history, you know it is an MI, it's there in the ECG. Don't wait for a CT, go with coronary angiography in a cath lab, get stents and everything done. CTCA is not going to save your life. Evaluation of coronary artery anomalies, as we all studied about a lot of anomalies there. Then we can have suspected coronary artery aneurysms, which are mostly common in Kawasaki disease. Then post-bypass graft patency. So for even a patient who has already got a stent or a bypass graft done, we can get a CTCA for that patient. We can check if there are re-stenosis, luminal narrowings, or something problem is there with the stents and the grafts. We can study that in CTCA easily. Then preoperative cardiac assessment prior to non-cardiac surgery. So you want to get a gallbladder operated, you want to get a hernia operated, but the patient is 80 years, 74 years. The anesthesia people come and tell you that the patient is a very high risk patient. The echo and the ECG are not very conclusive. They might be normal, abnormal. So you would like to get a CTCA done to get a confirmatory study done that the patient is not going to die on the OT table. So non-cardiac surgery, high risk patients. Then a transcatheter valve procedure. So we said we can look at the aortic valve. Transcatheter valve procedure, basically what we do is we go from radial or femoral artery and we replace the we put in a bioprosthetic valve inside. So aortic valve was not functioning. We got in from the arteries rather than having an open surgery. We got in from the arteries, went there, and we implanted a new valve. Simple procedure, looks simple, not so simple. So a TAVI requires complete coronary angiography study, complete coronary angiography and a aortogram. So a coronary CT angiography would be ECG gated, and aortogram would be a non-ECG gated study. So you will need exact measurements down to the 0.000 millimeters, where we will need the dimensions of the annulus, the aortic root, and everything. Plus, we would know the status of the coronary arteries and the aorta. That if you are going and getting a TAVI done, it's an expensive procedure in India as of now, that we are not going to lose the patient or the valve is going to support in that patient. The companies which make implants, they need that information up to the point millimeter study to put in the implant exactly. Now, how the CTCA helps in daily patient management? It rules in or rules out coronary artery disease quickly. It's simple. The patient comes in, you give some basic management to the patient, 5 minutes or 10 minutes just to manage out the heart rate, get the patient cooled down, go in for a normal CT with a contrast, put on ECG leads in 15 to 20 minutes. If the patient, everything is fine, the patient goes out in 20 minutes. So it's a good thing. Triage for invasive angiography. It avoids unnecessary catheterization. The cardiologist might be busy. You cannot have every patient with suspected chest pain go into cath lab. Plaque characterization. It assesses both calcified and non-calcified plaques. No other imaging can do that. A plaque in a invasive catheterization is a plaque. You won't be able to tell if it's calcified or a non-calcified. Why calcified, non-calcified? Calcified are stable, non-calcified are unstable plaques. Therapeutic decision makings. It guides the medical therapy, antiplatelet drugs, statins, lifestyle interventions. Do you need stent? Do you need a stent at 20%? No. A lifestyle intervention and a statin might be good enough. Advantages of CTC over other modalities, as we studied, compared to the invasive angiography, non-invasive, no catheter insertion risk, no risk of arterial injury. Compared to the stress test, which includes excise, ECG, nuclear, echo, we can have detect non-flow limiting plaques and directly visualization of coronary anatomy. Compared to the coronary artery calcium scores, we can provide detailed anatomical information. Calcium score is a non-contrast CT scan. So we just see calcium inside our coronaries and give a score. You are not able to tell if there is a low density plaque, that is a lipid plaque sitting in the vessel. That will be missed completely in a calcium score. So how do we help the cardiologist? So it can basically reduce the diagnostic catheterization. We can help the cardiologist choose catheters. It can identify the grafts, it can clarify the anomalies, we can evaluate the coronary lesions, we can prepare for coronary interventions as well. So these are some of the studies where CT angiography was compared to invasive angiography for stable coronary disease. And all of these are recent studies, 23, 24, 25. None of them are like 10 years back. Very recent, 1 or 2 years post-COVID. Everything is post-COVID. So randomized controlled trials have been performed. If you just look at it, we have a positive predictive value. Good number are more than 80%. And the best thing is a negative predictive value more than 95, close to 99, 99, 99. So what does it mean? Negative predictive value, if we say you don't have a problem, you don't have a problem. A positive predictive value, if we say you have a problem, we are close to saying you have a problem. So if I say you don't have any plaque, I'm pretty much 100% sure you don't have a problem. If I say you have a plaque which is obstructing 50% of your lumen, you might have a 50%, a 60%, a 40%, somewhere close. Calcium blooming, some problems are there, some limitations are there, which limits our accuracy in CTs. That's why catheterization, invasive catheterization are still the gold standards, not us. Then again, similar coronary, this was about native coronary arteries. Then again, a random controlled about coronary graft assessment. So when even grafts were studied with CT scans, we can see that negative predictive value were very good. Positive predictive value, yes, we were close to 90. Then we have our limitations and disadvantages. Now, radiation exposure, true. Even invasive angiographies have radiation exposure. Contrast related, again, same. Invasive angiographies have contrast related risk. Nephrotoxicity is there. Not ideal with patients of severe coronary calcification. If there is too much of calcification, the coronary blooming can be there, calcium blooming, which limits our accuracy with detection of how much is the obstruction. Then patients with significant arrhythmias and motion artifacts can be a problem. So we have a small video which gives you, not made by us, it was by John Hopkins. It gives you a small brief idea about how coronary angiography is done. So you are not afraid of telling why is it not such a complicated thing. So simple, you come in, go out. Nothing complicated. We don't know any pre-operative care. We don't know need any post-operative care. We don't need the patient to be in ICU. The amount of contrast is quite as similar to our CCT abdomen, and even less at sometimes. So coming forwards, now the radiology part, choosing the appropriate technology. So two things matter: how fast, how far. How fast is the temporal resolution? How far is the spatial resolution? How far is like spatial resolution means how far between 2 points we are actually able to see clearly. So a spatial resolution can be a 1 millimeter, 0.1 millimeter, 0.01 millimeter, anything can be there. Temporal resolution, how fast? The heart rate of a normal human being is between 60 to 100. If you're not talking any hypertensives, any arrhythmias, a person who is running, a person who is a person who is stressed. So the machine has to be fast. The machine has to be faster than the heart. So we two things can be done. We need to get the heart rate down, or we need to increase the speed of the machine. Acquisition. What does acquisition mean? That can be an ECG gated or a non-ECG gated. An ECG gated thing is important for the heart chambers, assessment of ventricle aneurysms, cardiac thrombus, cardiac tumor, evaluation of small pulmonary collaterals and pulmonary atresia, and for coronary artery assessment. If you look at them, small collaterals, coronary arteries, cardiac thrombi, small chambers. We don't want any of the motion to blur our pictures. Non-ECG gated for aorta, pulmonary artery, pulmonary veins. These are bigger structures. Huge structures, even with the patient breathing and moving a little bit, we won't mind that much. So there used to be three techniques: pitch, prospective, retrospective. which not done very much nowadays. Prospective and retrospective, let's talk about this. So prospective ECG gating is when we have a PQRST complex. So this is ECG gating. We had normal ECG, we take that on cardiac monitors in front of us. In prospective gating, we shoot at the point of the maximum diastole. Systole is the time when there is maximum movement in the heart. Diastole is the time when there is maximum relaxation in the heart. So 70 to 70 RR interval is the best time. So we move the table, the machine, we ask the computer to take at certain significant intervals. This is done when the patient is a normal patient who is not in arrhythmias, a controlled heart rate, and we can ask the patient to control his breathing properly. So and then the opposite of this is a retrospective ECG gating. A retrospective ECG gating, the machine is continuously on for various amount of cycles. The computer still takes the radiation doses at the same 70 to 70 RR intervals, but the only thing is that the continuous radiation is present, because in arrhythmias, in fast hearts, we need to know when this RR interval is coming. We are not able to predict. This might be a PQRS interval, then this much, and then this much. So we are not able to predict. The only downside, we are exposing the patient a little more. The good side, hemodynamic information which was supposed to be done, or was supposed to be in the forte of echo, now comes in the forte of CT. So studies have been done which says that hemodynamic information in a retrospective ECG gating is as good as an echo in today's scanners. Coming to the processing, computer does a good amount of stuff, then we come in. So then we come in for the interpretation. For a coronary CT interpretation, there are two parts, a calcium score and a coronary angiography. So for the calcium score, calcium can be done separately from a CTCA, or it can be as a part. We at our centers, we normally complement it. So the calcium score is firstly taken without the contrast, and then the contrast study is done. So calcium score is based on a Agatston scoring. Agatston scoring gives you a probability of dying from not dying, or gives you a probability of cardiovascular event in next 3 to 5 years. So in very layman terms, if you are going to get a heart attack in next 3 to 5 years because of coronary stenosis, the calcium score will tell you that probability. So coronary artery calcium scoring is divided into 0, 1 to 10, 11 to 100. We have a scoring. We'll see that also. So 0, completely normal. 1 to 10, just small speckles started to appear. 11 to 100, 100 to 400, more than 400. As it increases, the probability increases 5%, 10% more. Okay. So in most of us, you'll find in between 0 to 10. So 0 to 10 is considered quite normal. Who needs a calcium score? In India, I'll say everyone. Whoever has a family history of coronary disease, personal history of smoking, high cholesterol, high blood pressure, diabetes, overweight, or obese. So pretty much a good number of us fall in some of this category. So coronary plaque burden. Coronary plaque burden is when you do a calcium scoring and then divide it into P1 to P4. We have mild, moderate, severe, and extensive calcium scores. Another way of doing calcium score, by not doing a ECG gated calcium scoring, is visual inspection. So we had a huge number of chest CTs done during COVID. So we used to visually inspect them for coronary CTs, coronary calcium scoring. So if 1 to 2 vessels with mild amount of plaque, 1 to 2 vessels with moderate, so you can just estimate that find mild, moderate, or more amount if 1 vessel or 2 vessel or 3 vessel is involved. So we can give you pretty much closer calcium scoring if you don't want to have this thing. Then this is the P scoring. In this, the images are from the coronary CTCA, but we'll see the calcium plaques. This you see a small speck of calcium in the vessel, a larger chunk, that too in multiple 1, 2, 3. then multiple number of calcium speckles, then the whole artery is loaded with calcium. Now, how the computer or we do calcium scoring? Calcium scoring is not about the number, it's not about the size, it's about the volume of the plaque. So the higher the HU value goes, calcium score increases. The larger the chunk, the HU value increases. So if you have a 1 millimeter calcium of, let's say, 120 HU and another of 400 HU, the scoring will be different. The size won't matter there. So the volume matters and the HU matters. Then, when we come to classification, radiologists and orthopedics love classifications, even though we don't want to learn them. Cataracts 2. Cataracts 1 was in 2016, Cataracts 2 was in 2022. So Cataracts 2 stands for Coronary Artery Disease Reporting and Data System. Like every other reporting data system, we have a coronary artery disease reporting system. 0 to 5, no plaque, increase in plaques, N is non-diagnostic when we are not able to tell that what is exactly happening. So 0 can be 0, 1 means 1 to 24, 25 to 50, 50 to 70, 70 to 99, and 100% obstruction. Minimal to mild, moderate, severe. The best part of is we don't have to do any further cardiac investigation up till 50%. So if you are getting a 50% stenosis in the arteries, you are fine with lifestyle modifications and medicines. If it comes to 50 to 70, consider functional assessment. If it is more than 70%, we go for invasive coronary angiography because now you need a stent or a bypass grafting. So this was for stable chest pain. If you have an acute chest pain, troponin comes in. So the classification remains the same. Troponin is factored in. So the goal, standardize the reporting system, provide clear and consistent so that whatever I say and whatever someone in US is saying is on the same verge. It does not mean that if he's saying 25, I mean 50. If I'm saying 70, he means 20. So we all stay on the same pool. So 2016, 22, 1, 2 cataracts. Now the differences. Plaque burden was not factored in the 2016 cataracts. Now we have a P1 to P4. We just saw that P1 to P4 plaque system. So whatever cataracts you are doing, now you have to mention a P1 calcium scoring as well. The modifiers initially were 4. Now we have 6. The first is a non-diagnostic. We don't know what is happening. High risk plaque. The plaque is high risk. We'll see in the future coming slides. I is ischemia, S is stent, G is CABG, and E is exceptions. E is a non-coronary occlusion which is limiting the flow. So anything extramural. CABG, graft is there, stent is there, ischemia, we will see high risk plaque. So what are the features of the high risk plaque? A high risk plaque can be a spotty calcification, napkin ring sign, positive remodeling, low attenuation plaque. Low attenuation plaque less than 30 HU, fatty plaque, straight goes for high risk. Positive remodeling, basically there are two types of remodeling, a positive and a negative remodeling. Positive remodeling is something is growing outside the wall. So you have a vessel. Let's see this. Okay, so you have a vessel. If you say the plaque is going outside, you will think that it is a good sign. It is not going inside, it is not obstructing our vessel. But that is actually, when the studies were done, the positive remodeling is an adverse sign. Okay. Napkin ring sign, you will see that there is a central hypo followed by external hyper. Spotty calcification, a low attenuation plaque with a central spotty calcification. That's a spotty calcification. The modifiers, non-diagnostic, the patient moved, we cannot see anything. High risk plaque, low attenuation. Stent, we see the stent clearly and beautifully. So graft, we can see multiple grafts. The modifiers exception. This is interesting. So we have a coronary dissection, anomalous origin of coronary artery pseudoaneurysm, vasculitis, fistula, compression, arteriovenous malformation, anything which is not because of a plaque. Now we see some of the cases to get a better picture. So we see there's a small plaque, calcified plaque here. So if calcium is there, P will definitely not be 0. So we have 4. Now we see some amount of stenosis is there. When we saw it in the curved MPRs, we see that 10 to 20% luminal stenosis. So cataracts less than 25%, 1, less than 4 only, so it's P1. So cataracts 1, P1. Simple. Then case 2, we see that 1, 2. Two vessels have calcium plaque depositions. More amount of stenosis is present. So we have 20 to 30%, and with a calcium score of 284. So cataracts 2 and P2. Now we see that good amount of calcium is present, more amount of stenosis is present. So 50 to 60%, cataracts 3, P2. Coming to near total or total occlusion, that we'll have to check on the axial sections as well. We can see that there is no amount of flow in this section. So that's a cataracts 5, but only some amount of calcium is present, so P1. So now you understand coronary artery calcium is important, but it is not definitively diagnostic. It will give you a good amount of predictable probability score, but it will not tell you if you are going to get a heart attack or not. Then we have stents. You can see 3D, you can see the curved MPRs. Herein, the stent was placed in the patient for coronary stenosis, and the stent shows no restenosis. So you can see 1, 2, 3. 3 simultaneous stents were placed for a long block. Now, when the stent was done, there is, if you can see, no amount of restenosis, no amount of plaque inside the stent. Here, if you concentrate on the D image, we can see that there is something inside the heart. We are coming outside the coronary, we are seeing in the heart. So this was a left atrial myxoma. Pre-operatively, this was done. We can see in the 3D images that the pulmonary vein relationship with the myxoma. This was the myxoma which we took out, not we, the surgeons. And here we can see the left atrial RCA and the left circumflex. We can see that there's minimal stenosis, very less amount. So the main problem is the myxoma, not the coronaries. In this, we can see that a TAVI is done and grafting is done. So you can count 1, 2, 3, 4. 4 grafts are placed and a TAVI bioprosthetic valve is placed. We can see that there is no problem with the TAVI. Here we can see in the ventricle, left ventricle apex, a thrombus is present. Now the problem with this thrombus was that it was a high risk for invasive coronary angiography because it was already a post-coronary artery grafting. There were multiple stents you can see. The patient was evaluated for native coronary angiography, the patient was evaluated for the graft patency, and the patient was evaluated for the thrombus as well. There was no need for holding the oral anticoagulation. If you would have held down the oral anticoagulation, thrombus would have grown. So that's where CT helped. Now for choosing the guiding catheters. You can see that the right coronary has a very anterior takeoff and a curved takeoff. You can see that there is a good amount of plaque, which is causing a high amount of stenosis, but the artery is not just coming out straight. So it is, you need to decide on the catheters, which catheter exactly do you want to hook off for the stents. Here again, the proximal coronary artery has a high grade stenosis. You can exactly define the stenosis, how much stenosis or what length stenosis is there, and then you can help the cardiologist. If this much is the stenosis, you can go for this amount of stent. You don't need 1, 2, 3, 4. You don't need to have all the stents in your armada. You just need this much of stent, and you will be good to go. Then we have some advanced things. We have CT fractional flow reserve and perfusion scans. So what is the CT FFR? Fractional flow reserve. Coronary CT gives you how much stenosis, where is the stenosis. But FFR gives you the functional image. It gives you the computational flow dynamics on the 3D CT images. So if you have got coronary CT angiography, you are good with, you can use the same data for fractional flow reserves. And it is used if proximal stenosis are more than 40% with high risk plaques. So we'll show you in the image. The blue part is higher, that is more amount of flow is there. The green parts have less amount of flow in it. So less than 0.75 is abnormal. So we can see this part, this part, this part, they are having less part of, we can see the plaque is there already, but when applied on CTFFR, we can see that abnormal CTFFRs are present in the distal most segments, not in the proximal segment. Then CT perfusion, as in stroke, we used to study about the perfusion. We have a perfusion in heart also. Do we have a ischemic penumbra? Do we have an penumbra? Do we need to resalvage them? Are we able to resalvage the muscles? Then a brief runoff for the other anomalies. Here we can see multiple coronary artery fistulas, which are leading to such tortuous and dilated fistulas, coronary arteries. Tetralogy of Fallot, VSD, overlapping aorta, pulmonary artery stenosis, right ventricular hypertrophy. Double outlet right ventricle, we have a right ventricle which is giving rise to both the aorta and the pulmonary artery. Two ventricles are present, but the single ventricle is giving rise to both the vessels. In contrast to only single ventricle present. Right atrium, left atrium both give supply to the single ventricle present. Then we have a transposition of great arteries. Transposition means pulmonary artery arising from the place where it should not. Aorta arising from the right, pulmonary artery arising from the left. Can be corrected, can be uncorrected. Interrupted aortic arch. So very rare anomalies. We are actually great that we have seen two of such. The patient are actually alive. So arch started developing, in between got disrupted. So here we can see that the ascending aorta, the first two arteries are there. The left subclavian artery is arising from the interrupted arch. Now, where does this blood come from, if not the heart? So the patient develops collaterals or a PDA. And this was a Kawasaki case. Multiple aneurysms in coronary arteries. This is present in 25% of the cases in Kawasaki. Now, future trends in CTCA, AI integration. AI is coming in everything. AI is coming in everything. Lower radiation techniques, we want to lower down the radiation. We want to go on for fractional flow reserves. Take to work message. In our college, we used to have a take to work message. CTCA is a game changer. It is very ideal for low to intermediate risk patients. It helps avoid unnecessary invasive procedures, and it should be a part of the routine decision making, not going straight to the invasive coronary angiographies. Thank you. We have a lot of more things to cover, but we are short on time, so we had to rush through.
No, this was just great. I mean, you covered a lot, including, I think, a lot of clinical aspects. And in fact, if you look at the comments, Dr. Tahir from UK is saying one of the best presentations on CTC angio I've ever listened to, clear concept, best described the myocardial bridging concept, congratulations. And Slash has also said the same thing. Well, a lot of comments are coming, and I think they'll continue to come. Let's just go through the Q&A ones, if that's okay. But really terrific talk.
You see.
Okay, so a few questions from anonymous attendees. One is asking about TAVI measurements.
So TAVI measurements, actually, you start with the basic coronary CTCA. You check all the coronaries, you check in if they have any plaques or not, then you go for the ECG gated study. ECG gated study, we involve till the descending thoracic aorta. From descending thoracic aorta to the iliac fossa, we go in for a non-ECG gated. For the ECG gated study, we start with the aortic root, annulus, sinus of Valsalva, ascending aorta, aortic arch, descending aorta, and then the abdominal aorta at its various measurements. That is both in AP and TR, and then take out an average diameter for infradiaphragmatic infradiaphragmatic aorta just before the celiac artery, just post celiac artery in the suprarenal, infrarenal aorta, and at a point proximal to the bilateral iliac bifurcation.
Great.
Okay, so we have a question about medical control of pulse rate, how
Yeah.
to done before CT. So we have beta blockers, we have calcium channel blockers, we have nitroglycerin, we have ivabradine. So the most common is can be an oral, can be an injectable. Best thing oral. We as radiologists, I as radiologist, try to be very away from the injectables because then that gets in cases where we are not able to manage the cases. Oral cases, best of all, metoprolol, 25 to 100 mg tablets are available easily. Best thing, if you have either the patient is already on the antihypertensives, ask the patient to take the medication on the same day. Whatever he is taking on the normal time, normal everything, take for the pulse, count the pulse. So if you have a 64 slice scanner, best pulse rate would be 60 to 80, 85. We have done till 120. If you have a 128 slice scanner, 100 heart rate is good enough. If you have dual energy source scanners, you don't need anything. You don't need any drugs. Metoprolol 50 mg, good amount. It will give you good amount of control. If you have to go beyond 50, you can repeat 50 mg tablets for twice on the same day before trying to postpone the same procedure for next day, or taking into consideration something else if you have expertise, because we do give beta blockers and calcium channel blockers, but that needs some sort of experience with those cases, because a lot of things need to be factored in, including the patient's conditions. If is he asthmatic, diabetic, is he taking any other medications, is the patient old enough? So yes. Then use of ivabradine. Ivabradine is used for funny currents, so it does not control the heart rate exactly, but it gives you a good amount of control in the patients which have funny arrhythmias. They are not typical atrial flutters or fibrillations, but you know, see that ectopics are there. So ivabradine is a good control in addition to the 50 mg beta blocker. How to determine the amount of stenosis, like 50% or 70% stenosis? So what do you do? So when you are doing a cardiac CT, you have two computer screens in front of you. In one side, you see the axial section. Like just imagine you are seeing a chest CT. Okay, so chest CT on this side, and the other side you see a multiplanar reconstruction. Multiplanar reconstruction, what does that mean? Multiplanar reconstruction is one of the images we get as a simple straight line, like a coronary artery can be right, left, zigzag, curved. So in a reconstructions, we get a straight path so that we see the whole artery from proximal to the most distal part. Then we have reformats where we see the curved parts and we just rotate it 360 degrees. So they are inbuilt softwares which we get when you go for the cardiac licenses. So in that part, you see a complete longitudinal section and an axial section in front of you. Now, when you're getting an axial section, if you do carotid Dopplers, you just try to do that area and diameter stenosis, right? Like diameter stenosis, if you're getting outer wall to outer wall, inner wall to inner wall, same for the area stenosis, you go for the area of the normal wall and then the area for the area without the plaque. That is as simple. That gives you the percentage stenosis. Then we have use of CT versus MRI for congenital congestive heart disease, I'm guessing. Congestive heart disease, MRI is much better. You get to see cardiomyopathies, you get to see sarcoidosis, you get to see ischemias on late gadolinium enhancement. So coronaries and motion, if it's the problem, CT. If you are thinking inflammatory causes, MRI. because MRI itself is a two-class topic. If we just go for 2 to 3 hours, then we can just understand where MRI comes in cardiac cases. What length of myocardial bridging is significant? No length of myocardial bridging is significant. You cannot predict that. You have to correlate with the history. The patient might say that can be an incidental finding. Your patient is coming happily for a health checkup and you are telling them you have a myocardial bridging. The patient might come and say that I'm a 30-year-old man and I have severe chest pain while I'm exercising. So the segment length is not important. The amount of stenosis it is causing in the systolic phase. And if there is any ischemia or fractional flow reserve decrease, that is more important. Is there any cutoff calcium score above which you should do catheter angiography rather than CT angiography? No, there is no official cutoff for calcium scoring above which we should do catheter angiography. We are comfortably doing it at 4,000 calcium score as well. But it is a consensus that if it is going more than 3,500, we should probably look into invasive angiography rather than CT angiography. Okay, then MISA calculator does not include Indians and other high-risk ethnic groups. Which ethnicity is the calculator is closest to Indian ethnicity and is the percentile and estimated probability important to calculate? And is the percentile and estimated probability? Yes, the percentile and probability is important. You won't be able on the percentile when you have a calcium scoring. If you are actually going for the Agatston score, there is an inbuilt calculator in the CTs in which you enter the patient's age, BMI, smoking, non-smoking status, calcium score, and the computer will give you a percentile. If for that age, male sex, female sex, smoking, non-smoking, BMI, diabetic, non-diabetic, what is the percentile? Yes, it is still based on MISA calculator, not very much accurate for Indians, but then again, we'll have to start our own study, I guess, before we can tell them that why we should have Indian calculator. CHD, congenital heart disease. Okay, so if you're not talking about congestive heart disease, yes, congenital heart disease, CT is the choice. Because in congenital heart disease, apart from the coronary diseases, you get a good amount of extra cardiac anomalies as well. Wherein echo is a good supplement, but for extra cardiac information, echo has its limits. So extra cardiac anomaly, extra cardiac problems, we had this study in Calcutta wherein a pediatric cardiologist of ours, great one. So what he used to do, he used to do fetal echo on his own and used to send us cases for neonatal cardiac CTs. So babies as small as 1 month, 2 month, 3 month. We used to follow them up because since he had done his own fetal echo, he used to have this whole data. There's this congenital heart disease are present. Now he used to get it when the baby was born. He used to get a cardiac CT of the same patient and match his findings. So yes, we had a good experience in that. Fine, these much ultrasound studies are actually when the baby comes out and has a follow up, you actually find those studies. So CT, congenital heart disease, CT. So I hope so. I answered.
Take care of all the questions, Akshat.
Sorry, sir.
Really, comprehensive session and I think very clinically oriented, which was just great to see. A big thanks for doing this, and I'm sure we'll be having you back for future sessions as well. Thank you so much, and thanks to all attendees for attending this. I'll share the details of the attendees and the chats, I think, because some of them have really written nice comments. So I'll check that as well. But thank you so much. All right. Okay, guys. See everyone, and do log in tomorrow for the session on mediastinal masses. Jitesh from MD Anderson. Thank you so much. Have a good evening.
Recording.